I would like to invite now Dr. Swati Phuljhele to give her talk on pharmacological interventions in myopia. Dr. Swati is the additional professor at RP Center, AIMS, and she's a backbone of our pediatric ophthalmology services.
Good morning, everyone. It's nice to see you all here, and I thank Dr. Rebecca for giving me this opportunity to be part of her instruction course. Today's instruction course is very important kind of instruction course because myopia, as we know, is increasing, day by day. It's a huge challenge that we have to face maybe in coming times. So the prevalence is increasing worldwide, not just Chinese population or the South Asian population, which we used to believe earlier are more prone to myopia. No, it has been seen that there is the increased prevalence equally in Indian population as well, and probably some amount of increased incidence or prevalence in Western population as well. So it's worldwide, it's increasing. Of course, it's increasing at faster rate in South Asian region, but that's not stable, or it's not increasing in other parts of the world. There are multiple management options. The research is going on. A lot of people are working on a lot of things. And as we know more about the pathogenesis, which my previous co-instructor spoke about, we will know that how things can be changed. So the options are basically optical, pharmacological, lifestyle, and environmental modifications. So the last one is preventive, and as we always say that prevention is better than cure. So it's always better to expose children to that kind of lifestyle, outdoor activities, and try to decrease their near work as much as possible. Especially the work on phone, tablets, gadgets should be avoided as much as possible. Optical, I think someone else will be talking about, is probably the recent development in the management of myopia, but it's still not so clinically feasible because of the very high cost. It may or may not be effective, is a different matter, but definitely it's not cost effective. So, pharmacological management is what is clinically, routinely most practiced way of preventing myopia or preventing the progression of myopia. It doesn't prevent the myopia, it simply decreases the progression. It's the most accepted kind of treatment. So there are multiple, sites where these pharmacological agents can act depending on their receptors. So you have growth factors, you have antimuscarinic agents, growth inhibitors, which act at sclera and choroid. So most of these agents act at the level of sclera, retina, choroid, so that the synthesis, there is less growth of these tissues, and there is less elongation of axial length. Prostaglandins, dopamine analogs all have been tried and are still under research but not clinically available. So, atropine is the most accepted, most widely used pharmacological agent for the prevention of progression of myopia. As we all know, it's a non selective muscarinic receptor antagonist, and it's the only drug that is available for clinical use. It's also the most extensively studied drug, and it's like the as previous speaker spoke about, that the major problem with myopia or the major etiology is accommodation. So this is where the atropine comes into picture. It's a logical thing that something that will relax the accommodation will also decrease the axial length elongation. So, atropine in management of myopia, the most important study and most of our knowledge, our understanding of use of atropine in myopia progression comes from the landmark studies. The number one study is ATOM 1. It was a study where one eye was given atropine and other eye was used as control. And in ATOM 1, they had used the higher concentration of atropine, which was 1%. The study showed that there definitely was decreased myopia progression at the end of 2 years, while the fellow eyes grew at an average of 0.38 mm, which is very high in terms of axial length. There was also significant decrease in axial length in first year, but however, for the third year, when the atropine was stopped, they found that there was rebound increase in the study eye as compared to the fellow eye. So there was some major concerns about this study because one, it could be a little ethical issue there that you are treating one eye and you are using other eye as a control. There was rebound increase in axial length and of course the side effect of axial atropine like near vision blurring, pupil dilatation and stuff like that. So they followed up with ATOM 2 where they studied the lower concentration of atropine, particularly zero point 0.5, zero point 0.1, and zero point 0.01. That has been used in both the eyes for at least 2 years. And they found that there is a dose dependent relationship. That means, higher the concentration of atropine, greater is the myopia control. But they showed that the follow up study showed that the rebound effect was minimal with 0.01% atropine. So they concluded that at 0.01 atropine reduces myopia over the by 50% over the period of 3 years with the minimal rebound increase and minimal side effects in terms of pupil dilatation and accommodation loss. The next study, which is still currently going in the third phase, is the LAMP study, low dose atropine for myopia progression. It's again a randomized double mask placebo controlled trial to determine the efficacy of three different concentration of atropine, where they used 0.05, 0.025, and 0.01% and compared with the placebo. So they found that at the end of 1 year, 0.05 concentration showed the best efficacy in slowing down the myopia. In the third year, as you know, contrast to ATOM 1 and ATOM 2, where they gave atropine for 2 years in this study, they after 2 years in this particular study, they in one group they continued the atropine, while in the other group they discontinued the atropine, and they found that in the group where they continued the atropine, irrespective of its concentration, the results were better, the progression was less as compared to the group where the discontinuation was done after the 2 years. Right, so this is just to summarize the three major landmark trials as far as atropine is concerned. So what we learned from ATOM 1 versus ATOM 1 is that atropine works, but also there is a rebound. ATOM 2 told us that atropine in no concentration is a better idea as compared to atropine 1%. But LAMP is the study probably who is doing a randomized control trial along with a placebo group. It is showing us that 0.05% may have an edge over 0.01%, but we are still not sure about the long-term results. So this is an Indian study which was done from our center. It was a multi-centric study. Multiple centers all across India were involved in this study. And it was a randomized placebo controlled double blinded study again with 100 children, where we found that the mean change of spherical equivalent is in the atropine group was less as compared to the placebo group. Similarly, the mean change in axial length was also less, although not very significant, but less as compared to the placebo group. And no progression was seen in around 64%, while some progression was seen in around 13%, and a rapid progression was not seen in the atropine group as compared to the placebo group. So the idea is to know whom do we give atropine. Is it freely, should it be freely given to all myopic patients irrespective of the etiology, irrespective of cause, irrespective of their pathogenesis? So the idea is that it is basically used for a school myopia. That means myopia which occurs due to constant near work on school going children from age 6 to 14 years, in whom there is a clear cut documentation of myopia progression of more than 0.5 diopter per year, or if there is a spherical refractive error which is within -1 to -6 diopters. So let's be clear, it's not very effective, or I will say it has not been studied in high myopia cases. So anything more than 6 diopter, it is not yet, we don't know the results, even though people may give it, even though it's used clinically, but we are still not sure whether it works in those cases or not. In astigmatism, if it's less than 1.5 5 diopter. In anisometropia, if it's again -1 diopter. So the best corrected visual acuity has to be good. There should be no amblyopia. That is the idea. Otherwise, first one will have to treat amblyopia and then treat myopia. So, what is the thing that you need to know before you start atropine? When did the child first need glasses? How frequent is the change of glasses? That means how frequently his myopia is progressing. Is there any eye related issues? What is the child's lifestyle regarding particularly about reading, outdoor activities? Is there any parental history of myopia? Has the child taken any myopia control treatment previously? Is he or she allergic to atropine? And of course, child's basic history about his brief work or visual environment. So we start with basic ocular examination, which is the basic of all the ocular disease. But what is more important is cycloplegic refraction, which should be performed under either hometropine or atropine or cyclopentolate age appropriately. You can do autorefractometry or you can do manual retinoscopy. You can have to do both objective and subjective refraction. The main evaluation includes, which has to be done at baseline, is axial length measurement, amplitude of accommodation measurement, and pupillometry. Then we advise the full correction, glasses correction, full refractive correction, and atropine on at night for 2 weeks initially. After 2 weeks, the idea is to look at the any side effects. However, there are certain conditions where atropine is contraindicated, like Downs, if there is any congenital or heart disease, if there is cerebral palsy, if there is history of asthma, or if there is use of any other medication. In these cases, you may better avoid atropine. So the first visit at 2 weeks is just to understand whether the patient is having any side effects or not. The second visit at 2 months is to record the change in any visual acuity, if at all there is, or change in the amplitude of accommodation. Is the 6 month visit which is more important, and she will tell us if there is any progression or not. At this time, you have to repeat the refraction, repeat the axial length, and repeat measure the accommodation. So the treatment efficacy of atropine is judged by whether the myopia is progressed or not. That means more than 0.5 diopter change. Axial length has elongated over a period of time or not. And you also need to note the other ocular parameters like change in anterior chamber depth, keratometry, and lens thickness. How long do we give atropine? The ideal recommended by WHO is for 2 years. However, multiple studies have given it for 3 years and 5 years, but the recommendation is for 2 years. The patient needs to be closely followed up for the rebound effect once the atropine has been stopped, and also closely monitored for the natural progression of myopia. There will be certain 10 to 20% of patients who will be absolutely non-responding whatever you may do. Or they may be rapid progressors. That means in spite of your treatment, the progression is more than 1 diopter. The characteristic includes when there is a history of both parents being myopic, if the patient has had his first refractive correction at a very young age, and if the baseline myopia is very high. In these cases, you may have to think about the alternative therapy or the combination therapy or the higher dose of atropine. Many people are now shifting to 0.05% of atropine in these non-responding cases. But yes, we are still awaiting for the results in such cases. The other therapies would be taken subsequently through the course. There are other drugs, other anti-muscarinic drugs, which are still, under the research. There's no data to suggest the clinically efficacy, and most of them have been worked in animal models. The other basic concept of pharmacological management of myopia was to decrease the IOP, because sometimes they used to feel that the increase in IOP is what is causing the elongation in axial length, as we do see in congenital myopia. So that's one mechanism of pathogenesis. So that is also considered, but studies have shown that lowering IOP is not so effective measure to control the axial length elongation. Then the latest drug methylxanthine is also used, but is still under research. Dopamine agonists people are working on it and will have the results soon. There are other anti-myopic agents. I'll not go into details. So to conclude that there is increasing trend of myopia and we are facing it. So let's face it. We should understand what are the modifiable risk factors and devise preventive strategies, which is much more important than providing atropine. There are still lack of clinical guidelines for the use of atropine yet, but yes, myopia consensus statement have been published by AIOS, and we now have some consensus on the use of atropine as a pharmacological agent to halt the progression of myopia. The parents have to be made aware of the risk benefit of the use of atropine. And there's still unanswered question like, if atropine doesn't work, what is the next option, and how long are we supposed to give these options to the patient so that, after some point we can say that it's safe, we can stop here. With that, thank you.
Thank you, ma'am, for comprehensively covering the pharmacological interventions. So I would just like to point out that Indian children as such are low progressing cohort. So while you see a progression of minus 0.8 diopters a year in Southeast Asian children, our Indian children will show a progression of around minus 0.3. So that we need to understand. That's why when the LAMP says that 0.05% is the best concentration, it definitely suits the population. But what we saw in our population, based on the iAtom study, we found that 0.01% gives us very good results. Now, if there is a non-response or poor response with 0.01%, then you should try shifting to higher concentrations of atropine. And another catch is that 0.01% is commercially available. So it's very affordable and easily available to the patient, and 0.05% is not available. So you need to reconstitute it. So only in case of non-response or poor response, we consider shifting to higher concentration atropine. And of course, the mechanism of action of atropine, they believe that somewhere it's acting in the muscarinic receptors in the posterior ocular structures, maybe in the retina, sclera, RPO choroid, which in turn affects the scleral remodeling. So another just etiopathogenesis that Dr. Siddharth was discussing is the peripheral retinal defocus. So at 30 to 40 degrees in the peripheral retina, if there is a hyperopic defocus, then that's a stimulus for axial elongation. So that is why, these days peripheral refraction is being done for research purposes, where you are checking for the refraction at 30 to 40 degrees from the fovea using the peripheral autorefractometer. And based on this mechanism, we have these glasses or optical interventions with the peripheral